I'm Dr. Jonathan Salo. I'm a GI cancer surgeon in Charlotte, North Carolina. If you're seeing this video, chances are you or someone close to you has had an encounter with esophageal cancer. These videos are designed to educate you about cancer and its treatment and help you and your cancer team make the right decisions for you. Of course, there's no substitute for the expert opinion of your cancer care team. The topic of this video is locally advanced adenocarcinoma of the esophagus and gastroesophageal junction. We will consider cancers of the esophagus and the gastroesophageal junction together as the treatment is similar. The treatment recommended will depend upon the stage of the cancer. If you haven't already, this may be a good time to view the video on diagnosis and staging. A PET or CT scan is used for staging. If the scan shows that the tumor is localized without signs of spread beyond the nearby lymph nodes, it is considered M0. On the other hand, if the scans show signs of spread, this is considered M1. Patients with metastatic disease are best treated with chemotherapy and are generally not treated with surgery. We will focus in this video on locally advanced esophageal cancer. Locally advanced cancers are either T2 or T3 or node positive. If this terminology is not familiar to you, please refer to our video on diagnosis and staging. Locally advanced cancers are also M0, which means that there's no evidence of metastasis or spread to other parts of the body, such as the liver, lungs, or bone. To make things a bit more complicated, there are two types of esophageal cancer, adenocarcinoma and squamous cell carcinoma. The treatment of these cancers is somewhat similar but different enough that we've prepared a different video which specifically addresses squamous cell carcinoma. This video will focus on locally advanced adenocarcinoma. I'm occasionally asked by patients why we don't just remove esophageal cancer with surgery as the first treatment. The answer is a bit complex. When a patient is diagnosed with cancer of the esophagus, it can look like the cancer is confined to the esophagus. Sometimes what we see from the inside of the esophagus on endoscopy is just the tip of the iceberg. There's frequently spread of cancer cells into the tissue nearby or to the lymph nodes. If surgery is performed as the only therapy for locally advanced cancer, there's a risk that cancer cells can be left behind. Preoperative therapy is administered before surgery and is designed to shrink the tumor and to kill cancer cells in the surrounding area. This therapy typically involves chemotherapy and may involve radiation as well. The overall goal is shrinking the tumor and killing nearby cancer cells to make the surgery more effective. After preoperative therapy has shrunk the tumor and any other cancer cells, surgery can then be performed. Preoperative therapy combined with surgery offers the best chance to remove all of the cancer without leaving any behind. To summarize, preoperative therapy shrinks the tumor, makes surgery more effective, and leads to better cancer control than surgery alone. Preoperative therapy can also be referred to as neoadjuvant therapy. For adenocarcinoma of the esophagus, there are two different approaches to preoperative therapy. One uses chemotherapy and radiation together, followed by surgery. The other uses chemotherapy before and after surgery without radiation therapy. The chemotherapy and radiation strategy uses chemotherapy and radiation together. Chemotherapy is given intravenously once per week. Radiation is given 5 days per week. Both are administered together for 5.5 weeks. This is also known as the cross regimen. The chemotherapy is low dose, designed to make the radiation more effective. The therapy is generally very well tolerated. Hair loss is uncommon. Low blood counts are also uncommon and may occur in perhaps 7% of cases. The radiation can, however, cause inflammation in the esophagus called radiation esophagitis. This can make eating more uncomfortable during the last 2 weeks of radiation. The good news is that this is temporary and usually resolves within 2 to 3 weeks after the radiation is completed. What this means, however, is that placement of a temporary feeding tube may be needed. If a feeding tube is necessary, it can usually be removed by 2 to 3 weeks after the end of radiation. To summarize, this approach to preoperative therapy uses 6 weeks of chemotherapy and radiation together. Surgery is typically performed 6 to 8 weeks after the end of radiation, as soon as the patient has recovered. The second and somewhat newer approach to preoperative therapy for esophageal adenocarcinoma is treatment with chemotherapy, followed by surgery, followed by additional chemotherapy. Chemotherapy is given every other week for 4 doses, followed by surgery, followed by chemotherapy every other week for another 4 doses. There are 2 different recipes for preoperative therapy. FLOT chemotherapy uses 4 drugs, and FOLFOX uses 3 drugs. FLOT chemotherapy is more effective, and FOLFOX chemotherapy is better tolerated. To summarize, the chemotherapy strategy uses 4 doses of FLOT over 8 weeks, followed by surgery, followed by another 4 doses of FLOT chemotherapy over 8 weeks. Durvalumab is a drug that activates the immune system to fight cancer. The combination of FLOT and durvalumab appears to be more effective than FLOT alone. Durvalumab is typically given along with FLOT chemotherapy, followed by monthly doses. To summarize, this strategy calls for 4 doses of FLOT chemotherapy along with durvalumab, followed by surgery, followed by 4 more doses of FLOT chemotherapy with durvalumab, followed by 10 monthly doses of durvalumab. If we compare chemotherapy and radiation, or the cross regimen, with chemotherapy or the FLOT regimen, we see that chemotherapy plus radiation has fewer side effects, but FLOT chemotherapy is more effective. A central venous port is required for FLOT chemotherapy. And due to radiation esophagitis, a feeding tube is a little bit more likely to be needed with chemotherapy and radiation. Your medical oncologist will guide you in the decision regarding chemotherapy plus radiation versus chemotherapy alone. In general, FLOT is recommended for younger and healthier patients, while chemotherapy and radiation is recommended for patients who may have difficulty tolerating FLOT chemotherapy. There are several strategies to help you prepare for the preoperative therapy. Nutrition during therapy is important to get through the treatment. We have a video about nutrition during esophageal cancer treatment. Exercise is important to prevent muscle loss, which could increase the risk of surgery. And if you need any dental work done, it's important to check with your dentist about removing any potential sources of infection. In some cases, a feeding tube may be necessary. A central venous port is frequently needed for chemotherapy administration. We hope you found this video helpful. Feel free to leave a comment or question, or if you have suggestions for future videos. If you or a family member have had an encounter with esophageal cancer, I'd love to hear about your experiences, so please take a minute and leave a comment below. We're constantly creating new videos, so please subscribe to be notified of new videos when we post them.